Hello everybody. I'm delighted to have been invited to contribute to the Upscale project. I'm Caitriona Cunningham and today I'll speak to you about physical activity and exercise for people living with pain. I'm an Associate Professor in Physiotherapy at the School of Public Health, Physiotherapy and Sports Science at University College Dublin in Ireland. And I've been involved in the EFIC On The Move campaign over the last number of years. At UCD, I lead on physical activity and exercise teaching for the Bachelor's Programme in Physiotherapy. My clinical interest area and my research area is in musculoskeletal physiotherapy, and I've done work in relation to low back pain, bone health, musculoskeletal health services, and very much looking at physical activity and exercise for chronic disease prevention and management. So in my lecture, I'll speak to you about physical activity and exercise recommendations for healthy populations. I'll speak about determinants of physical activity and exercise behaviours. And then we're going to think about what the unique considerations might be for individuals living with pain. Now, the World Health Organization has a global action plan on physical activity, and they talk in terms of creating active societies, active environments, active people, and active systems. And they acknowledge that globally, 23% of adults and 81% of adolescents do not meet the global recommendations on physical activity for health. In so doing, they're acknowledging the socio-ecological model. This model recognises that there are many determinants of health behaviours, be that at the individual level, through a person's attitudes and beliefs, at the interpersonal level, where people have family members, work colleagues, friends who may influence, at an organisational level, and that could be a work, a sports, community organisation, at a community level, the organisations interact with each other. And then all of this is happening in the context of public policy. It might include transport policies, green areas policies. And the socio-ecological model contributes significantly to the theoretical understandings of engagement in physical activity. Now, there are many benefits to regular physical activity and exercise. These include a reduction in cardiovascular disease risk factors, decreased morbidity, delaying mortality, decreased anxiety and depression, improved cognitive function, enhanced mental health and well-being, enhanced performance of work and sports activities, effective prevention and management of many chronic diseases, and I refer you to a paper there by Pedersen and Salton. And we also know that exercise can reduce the risk of chronic pain. Now, before moving on to speak about pain and exercise, it's important that we revisit fundamental terminology. Physical activity is any bodily movement produced by the contraction of skeletal muscles that results in a substantial increase in caloric requirements compared to resting energy expenditure. Whereas exercise is a type of physical activity consisting of planned, structured and repetitive bodily movement done to improve and maintain one or more components of physical fitness. We also need to consider the difference between physical inactivity versus sedentary behaviour. Physical inactivity refers to an insufficient amount of physical activity to meet the present physical activity recommendations, whereas sedentary behaviour refers to any waking behaviour done while lying, reclining, sitting or standing with no ambulation, irrespective of energy expenditure. Sedentary behaviour is associated with negative health consequences independent of physical activity levels, and everyone should limit the amount of time spent being sedentary. For adults, physical activity can take many forms. It may be related to recreation, or it could be related to work activity, in the context of daily life. And the American College of Sports Medicine and mirrored by the Centers for Disease Control and Prevention recommend at least 150 minutes to 300 minutes of moderate intensity aerobic physical activity throughout the week, or at least 75 to 150 minutes of vigorous intensity aerobic physical activity during the week. Also, muscle strengthening is recommended at least twice per week. And here I'm presenting the Australian equivalent guidelines, and they're pretty similar to the previous guidelines, but they also make recommendations in relation to sedentary time, and they recommend minimizing and breaking up long periods of sitting, which may be very relevant for the pain population. With apologies to all who know these definitions, moderate intensity physical activity or exercise is represented by someone working at 45 to 65% of their VO2 max, or that can be classified as 3 to 6 METs, or at 65 to 75% of heart rate max. It corresponds to approximately 100 steps per minute, and the usual guidance we give is you should be able to talk, but you won't be able to sing during exercise. And now for a definition of vigorous intensity exercise. Well, somebody would be working at greater than 65% of their VO2 max, greater than 6 METs, greater than 75% of heart rate max, corresponding to 150 steps per minute, and unable to say more than a few words without pausing. As mentioned previously, we also want to consider interrupting or reducing sedentary behaviour. And put simply, sedentary behaviour is too much sitting as a distinct concept from too little exercise. It's also a determinant of cardiovascular risk, and it's an independent determinant. And it's important that we understand the detrimental effects of being too sedentary. My colleagues here at University College Dublin are currently researching effective strategies for reducing sedentary, as opposed to just trying to increase physical activity. And it's important to also consider strategies to reduce sedentary behaviours in pain populations, especially where fear of exercise exists. Perhaps reducing sedentary might be the first step in a continuum towards increasing physical activity. Now, looking a little bit more to exercise intensity. Well, the minimum threshold for benefit depends on an individual's current level of cardiorespiratory fitness and on their age, genetics, habitual levels of physical activity, disease status, etc. Moderate intensity is recommended for most healthy adults. Vigorous intensity is recommended for healthy exercisers, and light intensity is recommended for sedentary or at-risk individuals. When it comes to people living with pain, the Centers for Disease Control and Prevention's new opioid prescribing guidelines recommend a focus towards non-opioid and non-pharmacological treatments, which would include exercise. Epidemiological investigations also support the protective nature of physical activity on the development of chronic pain, and this may be due to peripheral or central mechanisms. And we know there is overwhelming evidence to support physical activity, reducing sedentary and exercise for the health of all, which also applies to people with pain. And looking to an overview of Cochrane reviews regarding physical activity and exercise for chronic pain, they looked at multiple clinical populations, and you can see them listed there: OA, rheumatoid arthritis, intermittent claudication, low back pain. And interventions they identified included aerobic, strength, flexibility, range of motion, and core or balance training programs, as well as yoga, Pilates, and Tai Chi. Outcomes identified in these studies included self-reported pain severity, physical function, psychological function, quality of life, adherence to the prescribed intervention, healthcare use, adverse events, and death. And so to the findings of the Cochrane Review. While the quality of the evidence examining physical activity and exercise is low, there are some favourable effects in reduction in pain severity and improved physical function, but mostly with a small to moderate effect, and they were not consistent across all the review papers. There were variable effects for psychological function and quality of life. But the conclusion was physical activity and exercise is an intervention with few adverse events. It may improve pain severity and physical function and consequence of quality of life. And now we just want to briefly visit, the science underlying why exercise might have a positive impact on pain. And a variety of basic science studies testing different exercise protocols show exercise-induced analgesia involves activation of central inhibitory pathways, opioids, serotonin, and NMDA mechanisms acting in the ventromedial medulla, promoting analgesia associated with exercise, and that fatiguing exercise can enhance hyperalgesia has been demonstrated in an animal study. And this paper looks at the concept of hypoalgesia that occurs in response to exercise. And in healthy pain-free populations, a single bout of aerobic or resistance exercise would typically lead to exercise-induced hypoalgesia. In other words, a generalized reduction in pain and pain sensitivity that lasts for some time after the exercise period. Whereas in chronic pain populations, this response can differ. It may see a reduction in pain, There could be an increase in pain or just no change. And so we need to be aware of this differing response when we work with people with chronic pain. And unfortunately, there's currently very little evidence to specifically inform us on how to tailor the parameters of exercise prescription for those people that have impaired exercise-induced hypoalgesia. Now, it's beyond the scope of today's lecture to get into too many individual studies, but I think it's important to have a nuanced approach to the prescription of exercise in people living with pain. And I'm just presenting a study here where increased pain sensitivity was found in individuals with knee osteoarthritis following exercise. And so we need to consider how we prescribe to these populations. And perhaps this is due to the loading nature of the walking task that was given in this program. And we may need to think more about how we modify exercise that avoids putting extra loading on specific pain sites. So if we acknowledge that people with chronic pain may have impaired exercise-induced hypoalgesia, what do we do about this in clinical practice? Well, a graded increase in physical activity and exercise levels seems intuitive. Perhaps making reduction in sedentary the initial goal in people who are very inactive would be the way to go. Sitting less, moving more. Introducing low-threat physical activity and exercise, progressing slowly, and helping people with chronic pain to reappraise the threat value that they associate with pain and movement. Now, given the prevalence of low back pain and the associated chronic pain, I just pulled up this review paper, and it looked at the types of exercise that are more effective than others in people with chronic low back pain. And of the 217 randomized controlled trials, there were almost 21,000 participants and 507 treatment groups. And the conclusion was that Pilates, McKenzie, and functional restoration were more effective than other exercise treatments for reducing pain intensity and functional limitations. Nevertheless, and this is where it always comes back to, people should be encouraged to perform the exercise that they enjoy to promote adherence. And now I'm moving to the whole area of exercise prescription and looking at the concept of pre-screening, which applies for all populations. So what is the purpose of pre-screening? Well, it's to identify individuals who may require medical clearance before initiating an exercise program or increasing the frequency, intensity, or volume of their current program. It's to identify individuals with clinically significant disease who may need a supervised exercise program as opposed to exercising independently. And in a small number of cases, you will find contraindications to exercise and you cannot proceed with exercise. Again, many of you will be familiar with the Physical Activity Readiness Questionnaire and the PARQ Plus, which has additional questions. And again, this allows you to establish the readiness of individuals to proceed with exercise. However, it is important to note that the American College of Sports Medicine is very strong on the need for more people to exercise, and that not many people really do require that additional visit to the doctor first, so that exercise is great for most people, rather than thinking of all the contraindications. But points to consider before starting to exercise or to increase intensity will be what's the current activity level, what are the signs and symptoms of certain diseases, and then planning an appropriate exercise intensity. And similarly, this will apply. People with chronic pain, there is a form of exercise that they can probably participate in once you've outruled any contraindication. Assessing physical function and physical activity levels should probably be part of all, primary care consultations, in the same way that we ask people about smoking habits, drinking habits. And the physical activity vital sign was developed to allow this to be easily embedded in healthcare practice. And similarly, when working with people with pain, this could be a very useful tool, asking someone on average how many days per week do you engage in moderate to strenuous exercise, like a brisk walk. On average, how many minutes do you engage in exercise at this level? And multiplying these to get a total number of minutes per week. Now, for individuals who are sedentary or who simply need to up the amount of physical activity in their lives to meet the recommended guidelines, brief interventions have a role to play. And really, these are defined as opportunistic advice, discussion, negotiation, or encouragement and can be delivered by a range of healthcare professionals, typically within 3 to 10 minutes. A brief intervention may include motivational interviewing techniques, an assessment of an individual's commitment to change. You'll be offering behavioural support, self-help material, and certainly people living with chronic pain may need more than a brief intervention, as do other patients, but it may be an important point, and it may be appropriate for the doctor to provide the brief intervention, or the primary care clinician, and then with onward referral to a physiotherapist or other exercise professional as needs be. Now, effective communication is critical for all patient groups, and certainly communication can be challenging when working with people who are living with pain. And the elements of a successful health conversation that would lead to somebody adopting or sustaining physically active behaviours would require the clinician to be person-centred in approach, to express empathy, to be non-judgmental, to offer support, and to promote a self-efficacy. Now, we know pain acts as a barrier to exercise for many people, and amongst physiotherapy patients, pain is a commonly cited barrier. Pain exacerbations are a major barrier to activity engagement, and it's a barrier that needs to be addressed if a patient is to benefit from exercise. Pain and the fear of damage can be really off-putting for people, and they may have lots of fear avoidance beliefs regarding becoming physically active. And so we need to help our patients to reconceptualize what pain means. We need to do a certain amount of education explaining what exercise-induced hypoalgesia is, but also talking about the need to build up physical activity gradually. We need to highlight that people with chronic pain may experience a hyperalgesic response in the early stages of an exercise program, but that pain does not equal damage. We need to discuss the potential for pain flare-ups, but again, it doesn't mean damage. And reconceptualization of what pain means to limit the likelihood of catastrophizing and reduce fear avoidance beliefs and behaviors. This is critical. Now, many of you are already familiar with the concept of pacing, and some people over activities on good days and then pay for it afterwards. And this can lead to frustration, loss of confidence, and increased pain. So pacing methods are used to set simple, realistic targets for your activities. And people need to know to set these targets and pacing methods following the supervised phase of exercise that they may have had on a pain management program. Here you can see the stages of readiness wheel and what's known as the trans-theoretical model for adoption of health behaviours. Now, it's criticised as a model as being too simplistic, but it has its value in considering where the patient's mind is when they meet you, the physiotherapist. Perhaps they're in pre-contemplation with no intention of taking action. They may be contemplating getting active, ready to take action. They may have made some small changes, or they may be active, or you may need to shift them across these phases to the point where physical activity has become part of their life, or planned structured exercise is part of their daily life. Interviewing involves a number of key skills, and it's really about empowering the person to take control of their exercise and physical activity behaviours in this instance. So asking open-ended questions so the patient has to come up with a solution. Using affirmations, confirming what they say. Reflective listening. Summarising. And other tools will be using scaling questions and decisional balance. So here's an example of a scaling question. On a scale of 1 to 10, how important is it for you to become more physically active? And you're getting the person to reflect on where they are on that continuum, and then asking them to reflect on the reasons for giving the number they do. Another question that's useful to explore is the level of confidence about becoming physically active or engaging in exercise. And again, trying to shift the person towards becoming more confident, so being autonomy supportive in your approach to physical activity adoption. Here are a template for the prescription of exercise. The key elements as always are assessment, but the focus here is on what type of exercise is required rather than thinking of diagnosis. Thinking, are there any precautions or contraindications? Then setting objectives at the impairment level, which might be the reduction of pain. And then at functional level, it might be going for a walk to the shop. It could be going for a jog. But make these specific, measurable, attainable, realistic, and give them a time frame. Then the exercise program itself, there needs to be a frequency, an intensity, a type and time. You need to consider what exercises or equipment is required, the location and progression. And then have decided what outcomes are going to be used to measure the efficacy. At impairment level, is it a reduction in pain we're looking for? Is it an increase in a range of movement? At a functional level, again, is it that trip to the shop or is it participating in some sport? Outcomes can be just in the behaviour zone as well. So it might just be about embedding physical activity in a person's life and looking at an exercise diary at the end of your session or the period of time with your patient. It's really important your patient knows how often they should be doing the exercise, how hard, and maybe starting it at lower intensity, particularly if you're fearful of that heightened pain response. For how long, be very clear what type of exercise, and then thinking about the total volume, which is the multiple of those three parameters: frequency, intensity, and time. And then considering progression. A reminder, a typical exercise training session will have a warm-up at least 5 to 10 minutes. The exercise duration, again, that might start low, 5 to 10 minutes. It can be progressed, typically up to 30-40 minutes, to incorporate aerobic, resistance or neuromuscular activities, or whatever it is that the client likes doing, because that's important to consider when you're prescribing exercise. Having a cool down, at least 5 to 10 minutes, and having some stretching. So these are basic prescription principles in exercise. Progression may consist of increasing any of the frequency, intensity, or time as tolerated by the individual. And during the initial phase of the exercise program, applying the principle of start low, go slow is prudent to reduce risks of adverse cardiovascular events, musculoskeletal injury, and also to ensure that the person becomes comfortable with the level of discomfort that might be induced. An increase in exercise time or duration per session of 5 to 10 minutes every 1 to 2 weeks for the first 4 to 6 weeks of an exercise training program is reasonable for the average adult. But you have to monitor the readiness for progression very closely in a pain population. Don't assume the above progression, and it may be more about forming the habits and getting the person regularly active rather than trying to increase the duration of the exercise they're doing. After the individual has been exercising regularly for at least a month, the frequency, intensity and time of the exercise can be adjusted upwards over the next 4 to 8 months. But ultimately, the goal may be simply to meet the physical activity recommended guidelines. Now, as for all patient groups, facilitating exercise adherence is critical. Having clear, attainable exercise goals, keeping the program simple. Discussing likely facilitators and barriers. This will include talking about what level of discomfort might be expected and what's acceptable. Discussing pain medications and the timing of these in relation to exercise, but caution that you don't get caught going down that route too much, because we want to keep the focus on an active approach. Discussing whether a group would support them better or whether they need an exercise buddy is also important. Any exercise that they have participated in successfully in the past, and then that's one to potentially go for as a confidence boost, certainly in the initial phases and maybe throughout the whole exercise program. Some basic guidance may need to be given on the use of footwear or orthotics. Again, not focusing too much on that and keeping the focus on the active. Consider any exercises which potentially could aggravate or any modification of these that are needed. Is there any disability that precludes a particular exercise being completed? Modify accordingly. Monitor adherence. Put the emphasis on achievement. Small steps. What are the things that you've achieved in the first week? Is it just about getting out and taking some physical activity? Is it about walking the kilometre? Is it literally about, getting up and moving from the chair, during a television program? It's all about enhancing self-efficacy and empowering the individual. You are guiding the person through a program, but it's ultimately about them taking on the behaviour, adopting it, bringing it into their life. Also discuss any lapse and focus on the next physical activity or exercise bout. So talk about potential traps. What are the days you're less likely to exercise? What do you see as the barriers? Discuss these. Certainly technology can play a role in promoting, monitoring of exercise and exercise adherence, and some will find it very beneficial. whether it's a phone app, whether it's wearing a Fitbit, whether it's following an exercise program on an iPad or on a screen. It's also very important to consider the context in which you're prescribing the exercise. And are you prescribing it in an environment that's conducive to exercise? Now, you may not have a gym, like this in your place of work, but certainly where we're based at University College Dublin, we found a major difference in clients being prescribed exercise in a gym facility as opposed to a clinical facility. And thinking about doing pre-exercise screening with people, so they're coming to physiotherapy for exercise versus the more traditional physiotherapy assessment where the focus may be on diagnosis. And that's been a major learning in relation to the delivery of exercise at our physio hub on the campus. Wikipedia has some nice guidance on prescription of exercise for people living with pain. It is important that we understand the parameters of therapeutic exercise for pain relief. We describe how to modify exercise parameters as they relate to the pain condition, recognize the importance of implementing adjunct therapies, and understand the importance of patient education. And you can access that yourselves on Physiopedia. EFIC has key learning outcomes that they want you to achieve, that you would have the ability to utilise a person-centred approach and have an understanding of how pain affects physical function, physical activity, that you would have knowledge of key elements of assessing physical function, physical activity and exercise participation, and that you would have knowledge of the key elements of pre-exercise screening, which we spoke about briefly today, demonstrate critical selection of appropriate, valid and reliable physical and psychological assessment and outcome measures. And again, remembering that some of these may be at the behavioural level. It might be about getting the person regularly engaging in exercise behaviour. And here you have further outcomes that EFIC have stated in relation to prescription of exercise and physical activity, and you can access these again. And here you can see the EFIC on the Move campaign on the EFIC website, and it's nice if you could access this. It gives you some information on this campaign, which I was involved in previously, and also a number of us have come together to prepare a position paper available to you soon. Here you can see an EFIC graphic about getting people moving from the On the Move campaign, and there's some positive messages here, and we really need to remember this, that the focus needs to be about empowering individuals, improving their self-efficacy, improving their self-confidence and being an exerciser. And remembering that small steps make a difference, and particularly that idea of reducing sedentary may be more appealing to some people with pain. And a further slide here outlining some of the EFIC tips on getting active. Now at this point I'd encourage you, if you have been sitting, to stand up and to engage in that good habit of interrupting your sedentary behaviour. And some take-home messages. Obviously this was a very overarching lecture, but some take-home messages from this. Physical activity and exercise should be recommended for the modifying effects on pain and general health benefits. Consider if you're targeting physical activity levels versus sedentary behaviours versus exercise behaviours. Sometimes we're doing all three. Sometimes it's more appropriate to just target sedentary behaviours. Adopt a behaviour change approach as you would for the general population. Encourage the people with chronic pain to consider the risks of being inactive. Consider additional outcomes other than pain in pain populations. Focus on the positive. Becoming active, the number of sessions completed per week, the physical function outcomes, and the reduction of other disease factors like cardiovascular disease. You need to be aware of fear avoidance, lots of reassurance, education, and empowering individuals. Guiding individuals to the expected response to exercise is really important. Can they expect soreness, and what soreness is acceptable? Guiding regarding pacing, when to do more, when to do less, but encouraging being active. Setting very clear, smart goals. Monitoring exercise adherence and measuring achievement. And being really clear that when you're with your patients, you're looking to the future. You're looking for a time when they're not coming to physiotherapy, and that's where you keep your focus. Consider how to sustain physical activity beyond the supervised phase. Be autonomy supportive in approach. Motivational interviewing as an approach is positive in promoting self-efficacy and specifically exercise self-efficacy. Now I know you may have many questions at this point, And the answers hopefully will be in some of the references I've provided for you, and obviously drawing on your own experience and realizing that the pain population, lots of the same principles apply for them, but with some unique considerations that we've highlighted today. Thank you very much for listening.